So what about practical prescribing? Please, I will not offend you by starting on a medical school level, but still we need to reflect on some practical issues when dealing. You saw my 3-pillar system. It's not my system, but it's a good system to think about the biopsychosocial framework where we have to take a decision on approaches, and one of these approaches might be pharmacotherapy, including opioids. And there has been written, and many papers came out, very negative papers over the last 24 months. There have been recommendations, and we will get a very nice example after the break by the Lance recommendation. But to have a framework, it's clear also from the previous talk that we need to take the decision on an individual basis by balancing what's available, what do we know, what is my own experience, and then only we can get into this decision. So patient selection is extremely important, and that means that a patient needs to be assessed very thoroughly. And this should be comprehensive, and this is not my scheme. It has been published by Charles Argoff, but I like this scheme, and because it also gives the importance and states the importance of this comprehensive pain management plan, which should include, and therefore I put up once again these 3-pillar system. And we should be aware that especially in chronic non-malignant pain, we should view the start of opioids as a trial. And therefore, every single patient you start on an opioid should be kept under your supervision. That's one of the points. You never, if you start as a pill mill, which means you give some opioids and then never re-evaluate the patient and just give some prescription, this is not pain medicine. So it starts with a trial, and that means if you start a trial that you have to reassess. So yes, it's time consuming. You will need some time, you will have revisits, and only then you can take a decision. Is this a workable principle, an approach within this patient? Just like you did take decisions, for instance, if you're involved in interventional pain management, you will not put in a catheter or a pump or a spinal cord stimulator only based on, okay, I'll put it in and then goodbye. No, you will do a trial and then you will take your decision afterwards. And then go further and have a re-evaluation of your patient. And that's the same is true for pharmacotherapy. And therefore, the reassessment is really critical. And then you decide to continue or to implement an exit strategy. And our last talk will go about the exit strategies. And always, within every stage, reconsider what are the alternatives and what can be the adjunctive approaches in this patient. A very simple slide, which is shown very often on the issue of opioids. It comes actually from the cancer pain management, where it's stated you know that you start with a very low dose, and especially in cancer pain management, you provide an immediate release as a PRN, and then you decide, is this helping? You increase the dose step by step. So this is an N-1 trial, and you're looking for a balance between adverse effects, but of course the level of pain intensity, and it's all about balancing. I do not like these figures in textbooks where it's stated pain-free, because we should be aware, especially in chronic non-malignant pain patients, pain-free is not a realistic goal setting. However, one of the false or one of the misleading concepts over the last decades is that many colleagues, by the destigmatization, had the impression that the sky was the limit, that you could go on and on and on with this concept. And there have been publications where it was clearly shown the sky is not the limit. And this is an example for cancer pain management, where only an increase in opioids was done, and you needed an accountant to calculate the doses and the switches of all these patches, and only one dose of a TCA, a tricyclic, put this patient in a respiratory depression. There has been a lot of discussion about MEDs, and this is not a complete list. Not every single opioid is on it, and for instance, the new one, tapentadol, is not on it. It's just to warn you that guidance about calculating these doses, the morphine equivalent dose, it's very useful to have a concept of how do I compare different dosages of opioids, and to have an idea, because sometimes you get confronted with a patient who is on a cocktail of opioids, and that's happening also in my country more and more. And so then my first role as a pain clinician is to put something in order, and therefore I need some concept of how much is this patient prescribed. And therefore it's very useful, but be careful. These are no hard rules. And be careful also with the information distributed on these small lineals and so on by several pharmaceutical companies. You should retitrate. You should be careful, reduce the dose, not just a one-to-one switch according to these MEDs. Actually, you should retitrate. There has been a long discussion, and over the last years, in most textbooks, it's promoted we should work with long-acting opioids. And several benefits were proposed, like more stable pain control, improved sleep. But quite a recent research, a systematic review from 2014, clearly showed that we do not have evidence for this concept. So there is fair evidence from short-term trials that long-acting opioids provide equal pain relief compared with short-acting opioids. And there is no evidence supporting long-acting opioids' superiority to short-acting ones in improving functional outcomes, reducing side effects of addiction. That was the outcome of the referenced systematic review by Peterson. So it's all about titration. So in the practical prescribing, if you do not go from an N-1 trial, you'll get into trouble, because then you really risk that actually the adverse effects are taking the overhand. And you know, sedation can be a problem in the beginning, but in many patients, tolerance will develop. Nausea, vomiting, especially at the startup or the increase, can be a problem. But in many patients, not in every single, but in many patients, tolerance will develop. Constipation, I'll come back also to that one. No tolerance can be a serious problem. And then, of course, there's a long list of other side effects, adverse effects you can witness with the use of opioids. And as stated by Dominic already, the main reasons for stopping are the lack of efficacy and the adverse effects. And we should always remember that opioids are very powerful analgesics, but also very powerful drugs that affect nearly every single organ system. So whatever, and I will not overview every single adverse effect completely, but I'll try to give some practical ways of how we can deal in. One of the most prominent ones is the GI system, the gastrointestinal system. And every single physical function of the GI tract is affected by opioids. There are many receptors around, also in the peripheral, in the myenteric and submucosal plexus, and there are interactions leading to different problems. So both peristalsis, tone, secretion, sphincter tonus are all affected by opioids. And this can lead to many problems, and the most prominent one is constipation. That's where your patient will complain of. Although my experience is that in my country, most patients will not spontaneously complain, only in a later stage. So you should be aware and ask for it, for these problems. But it's not the only problem. The first problem, or the first adverse effect after taking only one tablet of an opioid, is a dry mouth. This is the first fast witnessing of GI tract side effects because of reduction of secretion. But this can lead to many other problems, and not only the chemo trigger involved nausea and vomiting, but can also induce peripheral GI tract mechanisms of nausea. Just a remark that opioid-induced nausea and vomiting is not always transient or short-term. In some patients it can remain a problem. And there are some differences between the opioids. From a pharmacological point of view, there is some evidence that it also depends on the chemical structure of the individual opioid. And in a cancer pain setting, it can be very complex because nausea and vomiting can also be induced by chemotherapy, radiation, but also in a post-operative setting, there can be other reasons, the classical OINV as a reason for nausea and vomiting. Many patients have problems with constipation, but remember there are many other reasons for constipations, like other drugs. A lot of our chronic pain patients are on antidepressants, and these can also be very constipating, especially if you use the older tricyclics. Dehydration, electrolyte imbalance, especially a problem in elderly patients. And then you've got like a vicious circle. People reduce the dose because they think then it will get better, but we know that in these problems, GI tract problems, already start at very low doses. And what's in the textbook, give information. I think it's very important to inform before you start with an opioid trial that the patient is informed about not only the GI tract side effects, but all most common side effects. Fluid intake, fiber intake, physical activity, laxatives. These are the classic ones which are proposed, and there is not much evidence on I must admit, actually there is almost no evidence for every single of these measures towards opioid-induced constipation. You could have a look what are the societies recommending, what are the guidelines, and of course then we get back, although the topic is chronic pain and especially non-malignant pain, this line of thought has been rethought by the, for instance, European Association of Palliative Care, but also the ESMO, European Society of Medical Oncology. And there they clearly give the advice routinely to prescribe laxatives, and that eventually a combination of drugs with different modes of action can be beneficial, more effective in resistant constipation than a single agent. And then there are, at the publication of these guidelines, methyl naltrexone was around for palliative care. How do we do it in our center? And independent of opioids or cancer pain, non-cancer pain, we always give the advice to start with macrogol, a PEG, polyethylene glycol. It's not available or not very expensive in every single country, but the price dropped down dramatically over the last year, so this is our first choice, 1 to 3 units, and only if that's not enough, we will associate picosulfate, 10 to 20 drops every 48 hours, not to induce typical laxative problems, and then eventually switch to, or even add on the alternating days, bisacodyl. This is one of the schemes we use in Belgium, where we have limited reimbursement of certain newer pharmacological strategies. The same is true for anti-emesis, or if you look at the medications, there are many quite efficient anti-emetic medications available. Still, we tend to use this very old one, not the most unproblematic one, but it has a nice conjunctive action in these chronic pain patients. So we still like to use the old haloperidol. Actually, it was invented at near our university, Paul Janssen, many years ago. It's cheap, it works even in very low doses, and this is one of the actions which is often forgotten by haloperidol. And it's stated also, for instance, in the EAPC guidelines, it's also recommended. But in some countries, MCP, metoclopramide, are the modern ones, but more expensive ones are advised. Please be careful. There is some link with QT prolongation. So, and then there are the new kids on the block. Over the last years, we saw the introduction of the fixed combination oxycodone-naloxone. We are witnessing the introduction of the oral PEG naloxone, and methyl naltrexone has been available since a few years. There are other agents available in some countries, but not for this indication. And there is a lot of research, clinical research, also in phase 3 trials going on. So what we will witness over the next 2 to 5 years is an introduction of many pharmacological agents trying to counteract this constipation. Maybe a new concept is that in some patients you will notice that they are referred to a pain center with ongoing visceral abdominal pain. And actually, maybe this patient is not suffering at all from some visceral or abdominal problem, but actually is suffering from narcotic bowel syndrome, which is not the same as the constipation. It's an incompletely controlled abdominal pain that cannot be explained by any other causes. And I advise you to read this review article on the matter. Since we really have more attention to this, we could put forward this diagnosis several times in our center and in our referred patients. There is substantial psychiatric comorbidity, and actually this is one of the points where you really will notice that you are dealing also with an addiction problem. And the only way to treat this is complete detox of these patients, which is mostly not very successful because there will be relapse of prescriptions within 3 months. Also in our Belgian system, patients can walk around and get new prescriptions. Respiratory system, the sleep disordered breathing. This is something which actually appears in the normal population, 3 to 20%. If you watch patients and observe patients on long-term opioid therapy over 6 months, this can go up to 75%. Mostly these are not the dangerous forms of sleep disordered breathing, but in some patients this can lead also to hypoxemia up to 10%. And this is especially associated with methadone. So methadone, which is a very complicated drug and not advised to use as a first line. And if you look at there is a link with the dosage, and that's one of the reasons that a lot of the American societies really want to push forward these morphine equivalents, because they found, because of the uncritical prescription, there were emergency department referrals or patients in respiratory depression, and there was a clear link between the dosage and the occurrence, stating that 50 to 100 milligrams MED, 3.7 hazard ratio, and then for over 100 milligrams it went up to almost 9. Also in the cardiovascular system, there are a few studies who have shown that there is some link with cardiomyocardial infarction, but the most prominent one is once again methadone, where the QTc interval prolongation can lead to very serious cardiac arrhythmias. And there is also an association with age, gender, hypokalemia, and hypomagnesia. And therefore, if in the switching of opioids at a certain stage you would decide to use methadone, please watch these patients. You have to follow them also by ECG, and there is no common advice what are the exact thresholds to decide not to to prescribe methadone, yes or no. What we do is for male patients we have the cutoff of 450 microseconds. For female patients we use 475. If there is a prolongation, we stop the medication. And there are many interactions with other drugs. If we go to hypogonadism, it was briefly already mentioned by Dominic. Actually, putting patients on long-term opioids, these patients should be informed beforehand that you will castrate them, because that's what is happening. And it's all part of the multimodal approach, because what we teach our patients is to take common shared decision making. And in some patients, the workability principle says that, okay, I would take this risk for getting a better quality of life, and even if I've got to give away this part of my life. So this is once again balancing at adverse effects. So decrease in libido, fertility, muscle mass, osteopenia, anxiety, depression, and then there are very sex-specific changes. Females get amenorrhea. This can happen very fast with opioids, oligomenorrhea, and erectile dysfunctions. Most of our male patients on long term are also on testosterone replacement therapy together with the endocrinologic department. And these mechanisms are well elaborated, they're well documented, so if you're interested, you can have a look into these mechanisms. What about the musculoskeletal system? There is an association between falls, the risk of falls, and the long-term use of opioids. There is an increased risk of fractures. If you compare it, for instance, in low back pain, osteoarthritis between NSAIDs. But mentioning NSAIDs, we should be very clear, NSAIDs and even paracetamol also have a huge variety of adverse effects. And maybe we should have included also a direct comparison between the occurrence of major adverse effects of NSAIDs compared to opioids. So it's on another level, but still the choices are sometimes difficult to make. And then there are questions about the immune system. I remember when I started in lab as a fellow, after the clinical hours, we had to induce in mice a complete immunosuppression, and the trick was very easy, just inject a high dose of morphine. And these mice get immunodepressed. Now there are other ways to do it. But clearly morphine has an action on the immunological system. But remember, if we go into the mechanisms of pain, pain has to a large extent the same mechanisms by indirect and direct ways on the immune system. So chronic ongoing pain reduces the immune system, suppresses the immune system, and by treating the chronic pain with opioids, we can also, it's not clear what's the balance. We are taking away the pain, and maybe we lose these effects on the immune system, but we do not know the net balance. Although there are differences between the several different opioids, and there are some opioids which are more responsible for immune suppression, and others are more neutral than compared to the others. And then this has, of course, also put questions, what are the immunomodulatory effects? At this moment, there is no evidence that from clinical studies that opioids leads to a significant and clinically relevant increase in infections, nor perioperative ICU acute or chronic pain, and no direct link has been conclusively demonstrated. So we cannot exclude, according to the present data, that opioids might cause clinically relevant immunosuppression. So still things to clear. And then, of course, people ask, okay, we were confronted with many cancer survivors, but many of them are still on opioids. What's the risk on the oncogenesis? And this role is far from unclear. There are no reliable data demonstrating that opioids are directly involved in tumorigenesis in humans. There is some evidence from animal experiments, but at this moment, no ongoing evidence or published evidence in humans. And then the central nervous system, I will not talk about addiction because Professor Tolle clearly will also talk about getting aberrant behavior in patients on opioids. But we should be aware, especially in elderly patients, that dizziness in combination with sedation and eventually increase in osteopenia can also be the reason for these falls. Hyperalgesia has been discussed by Tony Dickinson with the excessive sensitivity to pain, and there is a higher level of comorbid clinical depression. So the major problem is the polypharmacy. If you've got a patient and you're doing a trial on opioids, but this patient is on 3 different benzodiazepines and other psychotropic drugs, I'm very reluctant I will not start immediately or think to add. I would go first for a rationalization of these other psychotropic drugs because this really can be a problem. And then To end with, we have to be, often the question is asked, what do we have to do with opioids and hepatic impairment? First of all, you cannot be guided by a single lab value. It's not depending on OT or transferase or gamma-GT that you will decide, will I adapt? And if you stick to the principle, start low, titrate slow, and re-evaluate patients, that's the most safe advice we can give. And based on the literature, actually reducing the dose and re-evaluating the clinical status is the most effective and safe one. The same is true for renal impairment. Every opioid should be titrated individually, and you should be guided by the clinical effect, not by the biochemistry. You need to adjust for almost every single opioid dose. One of the exceptions is buprenorphine in this case, and in severe renal failure, so we're talking about creatinine value of more than 3 milligram percentage or a filtration rate less than 15, there is a preference for buprenorphine, fentanyl, or hydromorphine. And in end-stage renal failure, dialysis, some of these drugs will be dialyzed, and you need to give a new dose just after dialysis. To conclude, practical, how you can deal in a practical way in a scheme. Assessment, reassessment is extremely important. So you need to do this comprehensive assessment. It's a tightrope walk, an N-1 trial. So individual goal setting is important. You should discuss before you start it what will help us to decide if we continue yes or no. Clinicians should pay more attention to the long-term adverse effects, because you will also lose patients if you do not have attention to the treatment of adverse effects, because maybe there are patients who can benefit from long-term opioids who you will lose because of laziness in reassessing adverse effects. But yes, opioids affect almost every single organ system, but be aware that the adverse effects of other analgesics, especially NSAIDs, non-steroidal anti-inflammatory drugs, and even the role of paracetamol is being reconsidered over the last year, because there is a clear association with hepatotoxicity, even within the normal recommended doses. So yes, pain and undertreated pain affect almost every organ system also. So maybe it sounds a little bit negative when we state all these adverse effects, but be aware pain itself will also affect a lot of these organ systems. And we should be aware we had the pendulum swinging over from stigmatization to destigmatization. Maybe now we're in a phase of over-destigmatization. But addictive properties of these drugs should not be minimalized. We should not say, no, there is no problem, but there are ways to deal with this. And after the break, we will continue, and we will hear some practical advice how, for instance, in Germany, the German Pain Society, together with a whole group of experts, put forward recommendations to deal with the use of opioids in non-cancer pain. I thank you very much for your attention indeed.